now I'd like to invite Dr. Murali to come and speak on pharmacological therapy for myopia, and I think something that we've all been using of late for these cases. Over to you.
So thank you so much for having me as a part of the symposium. Like most diabetics who don't like lifestyle changes and are happy taking a medicine, I think even in myopia, we often are quite happy to look at medication to see if we can control the condition, so to speak. So I'm here to speak about it. I would like to acknowledge my colleagues, Dr. Vidya, Saumya, Vandana, and Amrita, who helped me with some parts of what I'm going to be presenting here. So when we look at managing myopia, largely it has been correcting the mismatch. Either we give glasses or we wait for them to get older and the power to stabilize and then provide a refractive surgery to them. Both of this kind of takes care of what the challenge is. But I think today, looking at Dr. Meenakshi's slide, we know that myopia is a huge problem. Progression is a larger problem, and we need to see what can be done to control this progression. So there have been multiple meta-analyses that are done, and a range of interventions have been tried. If you look at it, it varies from as broad as acupuncture to lifestyle changes to medication to a variety of soft contact lenses to even undercorrection that used to be proposed earlier. But most effective interventions as on date continue to be pharmacological interventions, and largely these are muscarinic antagonists like atropine and pyranzepine. Atropine, of course, is the only drug that is available today in India for us. Again, when you look at medicines, a plethora of medicines have been tried. Again, as I mentioned, large number of them have been muscarinic receptor antagonists that have shown to inhibit the developmental myopia in a variety of animal models and also in human studies. Pyranzepine has been shown to reduce myopia, but unfortunately, this is not a product that we have available with us. Clonidine, Yonfacin have all been used in animal models. Again, these have their own innate side effects, so we are a little diffident to use it. Intraocular pressure was shown to be a risk factor. Again, a variety of anti-glaucoma medicines were tried earlier that had neuroprotective effect. And recently, a drug called Crositin was actually injected around the eyeball, which showed that it slowed down and had a role play as an anti-myopia agent. It doesn't stop there. 7-methylxanthine has been used. This again has been shown to reduce not just the progression but also axial length elongation over a period of time. This was an interesting paper. I found it interesting because one of the comments on that was saying that, oh, there's been a surprising number of drugs that have been tried. So presently, although in human trials we have only atropine, pyranzepine, and 7-methylxanthine, a variety, look at it, from ketorolac to oral riboflavin to an experimental drug BHV12 have been used. Mechanisms, again, a variety of hypotheses from anti-muscarinic effect, dopaminergic effect to anti-inflammatory effect, a variety of modes in which we've actually used them, from eye drops to medications to injecting them intravitreally and subconjunctivally. Long story short, we seem pretty lost and we are not happy with the options that we have. Atropine has kind of stood the test of time, and again, a variety of mechanisms have been proposed in terms of how atropine works. The primary site is pretty controversial, but recently studies have shown that it probably has a role play right from the dopamine receptors right up till the cornea in terms of how it works. Is it something new? No, it was used by Wells in 1900 to stop by paralyzing accommodation, so that's how old a medicine it is. And the first randomized trial was in 1989. Again, there were other trials done in 1999, but some of these lacked randomization, lacked biometry principles. The atom 1 and 2, by and large, are what we kind of hold the practice of use of atropine today. Atom 1 showed that atropine was well tolerated. Atom 2 showed that 0.01% had minimum side effects and again retained efficacy with minimum rebound. Prior to this, atropine was not commercially available. We actually did a small study where we reconstituted atropine and we used it in children and showed that it was very safe. Why is this important? Today we are looking at the LAMP study that says that higher concentrations of atropine possibly may be required, and when you don't have access to commercial applications, it is not a bad idea to reconstitute it. In our own practice, we have found that using 0.01% atropine twice a day seems to work very well. at max, we've had to use 0.02. As on date, we have probably 2 children who are on 0.05%. So we've not really found the need to use a higher dose of atropine in them. The lamp, however, showed that there's a dose-dependent response, and 0.05% was the most effective over a period of 1 year. So this again has been done in the Eastern Asian population. In our population, again, we probably need to see what happens with it. We've again been tracking some of our children over a period of time, and we found 0.01% to be extremely effective, both in terms of control of spherical equivalent as well as the axial length elongation over a period of time. How difficult is it to use? We've again got some kind of qualitative insights from parents, because invariably they're the ones who you need to convince. The child doesn't have much of a choice in what is being put on the eye. So most of the parents, in terms of feedback, is that there is an initial discomfort and they get used to it quickly. There is some amount of fear mongering that does happen, saying that if you don't do this, your power is going to go up. And some of the older children are, of course, much smarter. They are able to understand and start using these medicines. And still, the doctor is important to the child. They do listen to us. Is atropine the know-all? No, there are multicentric studies that have shown that it doesn't work as well in the Caucasian population. This has been seen in UK. This has been seen again in Israel, as well as a part of the PEDIC study. So again, there seems to be some change there. So atropine obviously is not the magic bullet, and patients do find it difficult to use it year on year, and they also have sometimes a challenge in terms of accessing the drops. Putting a drop into the eye because of the preservative again causes stinging. Again, this is a very interesting study from Sunny where they've looked at kind of nebulizing it and spraying it on the eye. We had tried some of these earlier. There are some publications of using it as dilation drops in the OPD. We've not found the dilation drops to be very effective. Again, the absorption, we're not too sure how it's going to work. Again, atropine by itself may not work. You may need to add it in. Like Meenakshi ma'am mentioned, outdoors is important. We found that in children on atropine who are spending time outdoors, there is a definitive additive effect. Again, not just atropine drops, even vitamin D we found to play a role. When you normalize it, or in children who are progressing, invariably the D3 levels are less, and correcting it may have a role. With atropine, start-stop is again something which is anybody's guess. We're still not very clear. Do we stop it at 15? Do we stop it at 21? Do we continue it on? When do you start it? Today we've now started talking of pre-myopes, at-risk population. Do you even start it on them or wait for them till they're older? Levodopa, again, is some interesting studies that are there. Unfortunately, again, this is a molecule not available in our country. This has again been shown in a small placebo-controlled study to actually be effective. It has both inhibited experimental models. It had minimal systemic distribution and did not affect the ocular development. There is one trial that has been published. Hopefully we will see more of this, because if atropine is working on the dopamine mechanism, why not just increase the dopamine availability in the eye? Currently, there obviously is no definitive method to prevent progression or reduce its prevalence. There is a lot of uncertainty, and we need to keep at it, keep sharing information to see how we can find a more appropriate solution to slow down the progression of myopia. Once again, I thank AIOS for making me a part of this session.
Thank you, Dr. Murali, for a very comprehensive talk.